You're really lucky, and if this is your first conference, you don't know these guys, but if it's not your first conference, you're probably almost familiar with Dr. Robert Hopkin from Cincinnati Children's and or Dr. Daryl Scott. Dr. Hopkin, just to give you his background, and there he is, he works at Cincinnati Children's. He's trained in pediatrics and in genetics, and he finished his residency in pediatrics there in 1994, completed his genetics training in Cincinnati in 1997, and has continued on there. And I think the most important part of his bio is the last sentence, which says, the unifying principle in his research interests is the application of scientific knowledge to improve outcomes for patients afflicted with genetic disorders. And I think that means he wants to help us. Likewise, Dr. Daryl Scott, I'll skip the first part of the bio. He went to medical school, then he got a PhD, then he did 2 different residency programs, which means he was in school till he was like 35. And I'm not going to try to tell you what his age is, but he does a lot of research into genetic disorders and how do we translate the information from looking at genes into what that means for an individual. To sort of boil it down, he's at Texas Children's. We always have a Texas contingent. And I'll read the last sentence of his bio, which is, more importantly, he and his cute wife, April, have 7 children ranging from ages 25 to 5. Sometimes he has brought all of them. This year, he just brought Gideon, which is probably a great relief for Gideon, because if I had 6 siblings, the idea of going away without them would be the greatest thing in the world. So suffice it to say that these guys very much know what they're doing. Genetic disorders is their bread and butter, although they do a little bit different kind of thing from each other. They are incredibly knowledgeable. Both have spoken before and given us talks, but we thought maybe we'd do something a little bit different this year and just have people submit questions, and we'll do some questions from the audience as well. But I just took the questions that people submitted and I sort of boiled them down, and so your question might not be exactly as you submitted it. I apologize. But I think we're going to cover most of the topics that people asked about. And I'm just going to let them decide who wants to answer what and go back and forth. So I think the first question is, what is the current state of research regarding 1p36?
So there's not a whole lot of us that actually work on 1p36. I'm probably one of the few that I know of. Our laboratory continues to work trying to identify which genes do what in the 1p36 area. And so our main focus is we use mouse models, and we take mouse models of individual genes, and we try to translate that into knowing what it does in a mouse, and then saying, okay, does that gene do the same thing in humans? And so we've had some luck in identifying some of the important genes that cause that, or cause different symptoms or different problems. I focus especially on things like heart defects, eye defects, hearing loss, things that I can model easily in mice. And that's the kind of, it would be the basic science research that's typically being done in 1p36.
So the research that I have done is not nearly as laboratory oriented as his. There are some things being done. The speakers yesterday that were talking about the behavioral interventions, I talked to them briefly after their talk and said, hey, I want to collaborate with you if we can get something together, because this seems really important. That kind of research can be done. I'm not aware of a lot of current projects being done. I also want to mention that there are some other people interested in genes in the 1p36 region. I was contacted just before this meeting by a researcher at the NIH who wants to look at eye problems in kids with 1p36 deletion, specifically focused on a single gene. So I don't know what the status of that is, but I do know that there are people who are interested in this, and I also want to let you know, if you have clinical questions, I would love to hear them, because I find that families have much more practical projects that I can sink my teeth into. than I do, because you know what it's like to be with your kids every day, and I don't.
I know a little bit about that because the email was forwarded by Dr. Hopkin to Jenny, who forwarded it to me. I contacted that person. They are interested in some of the genes in the 1p36 region, and specifically that have to do with vision and the eyes. I think they're interested in doing something, but whenever you put a research project together, it's got to be approved to say that it's ethical and acceptable to do. You can't do that in like a week. But there is a possibility that that person may be interested down the line and in a year or two put something together in some kind of research project. But I have their email and we emailed back and forth. So every once in a while we come across someone like that. I do know that Dr. Hopkin and a student of his, former student, Ashley Brazil, published that study I talked about in my talk about 1p36ers 12 and over and the kind of stuff that they experienced. So dovetailing with that, the next question is there anything you can think of, medically speaking, that would be more likely to show up in a teenager or young adult or older 1p36er that might not show up in the pediatric age group, right? So most of the time when people develop seizures, they're 2 and under, but I know reported as old as 15. But is there anything we can think of in terms of older people? I don't know, because I don't know that many that are, over 25 or 30.
Neither do we. We tried to find them. Ashley and I actually wrote letters and made phone calls and contacted people in Europe and Australia as well as the US looking for adults. And we heard rumors of people as old as 50, but we didn't actually get information on them. So if you know of those people, I'm still interested in figuring it out. And we don't have any data on the older patients with 1p36 deletion. Based on what we have seen in the younger patients, there are some things that I think we should pay attention to. Seizures continue to be a problem. Chronic aspiration or even new aspiration events in older patients appeared to be a risk factor. In both the cardiac study that we did during this meeting when it was held in Cincinnati and in Ashley's study, we found young patients but older than middle childhood who had evidence of progressive cardiomyopathy. So continuing to pay attention to the heart is very important. I'm hoping that Dr. Scott can tell us which genes we should pay attention to on that. And then complications related to chronic disease. So for example, the kids that gain excessive weight or that have low muscle tone, we know some complications of those problems that become more severe as the kids get older. So we should definitely pay attention to those issues, and that would be things like back pain or knee pain, sometimes pulmonary issues, things like that. So we have some idea based on those things, but no actual data from a large group of adults with 1p36.
And I guess scoliosis would sort of fall into that category of something that can be progressive over time.
It can. Usually once they're grown, the scoliosis itself is not going to progress once they've stopped growing, but pain related to the scoliosis can increase over time, and especially if their movement pattern is not normal, which I think would apply to many of the patients with 1p36.
So I'm going to kind of try to throw each of you a question so you can alternate and not have to talk. So I think this is more in Dr. Scott's ballpark. But what can you say about the relationship between what genes are missing and what that means in terms of the problems that an individual might have? I mean, you can both respond, but however you want to do it.
So actually, there's a whole bunch of other individuals who are actually working on the same problem, but in kind of a different way. So nowadays, we have several different genetic techniques that can look at all the genes at once. This is kind of a roundabout way of answering the question, but may be useful. Most of your kids will have been diagnosed using a chromosome microarray analysis, which shows you what piece is deleted. It's one of the first tests that was developed as far as being something that we can look at all genes at once, and it looks for big pieces that are missing or extra. Usually the pieces that are missing or extra that we find are big, and most of the kids that have 1p36 have big changes where many genes are affected. That can be difficult because those genes all can work together. So, for example, we know that there's at least 5 different heart genes that cause different heart problems, like holes in the heart, etc. At least 5, but there's probably even more than that. And when you delete 2 of them, then it can add together. This is the complexity. One of the things that's happening that's new is we can now have techniques that look at all the individual genes by themselves, and we look for mutations in those genes. What that lets us do is now there's a whole bunch of doctors all over the world who are trying to identify what happens when you take out just one gene. Like, what if one gene doesn't work correctly? And so I get emails probably on the order of every other week, or maybe even every week, from different people who are looking at the same genes that we're interested in and saying, I have a patient who has a change in this gene, or I have a patient who has a change in that gene. And we take these groups from all over the world, and we try to identify what are the genes that are the most important. And so again, we try to figure this out. And if you can identify one gene that causes, let's say, the seizures, that may be just one of the genes that causes seizures, but then we would know that every time that gene is deleted in someone, we should be thinking about the possibility of having seizures. Or we look for a heart gene, we say when that gene is deleted, we should be worried about heart. Now, it's not always 100%, which means that not always will you delete a gene, will you get a specific response. One of the reasons for that is that 1p36 is a deletion of one of 2 genes, right? So you have 2 different chromosome 1s. Because of that, how the other gene on the other chromosome responds can make a difference. So just as a for instance, let's say you have a gene on this side that causes heart defects or gets you higher risk. It may be that the gene that's left is working a little bit better than it should. In that case, a child may not have the heart defect. But if that gene is also weak or does not work as well as it should, then this child would then be at high risk. And we see this in many different genes, where some children are very affected by just missing one gene and other ones are not because there's compensation. So long answer, but basically yes, individual genes are responsible for individual symptoms. But again, most of our kids are going to have multiple genes deleted, and they may be adding up and working together to cause a problem.
So it sounds like it may put you at risk, but nothing's really definite. You can't say if you're missing this particular gene, this is definitely going to happen.
Yes, almost always that's the case. Almost always we are looking for something or more worried about something because of a gene being missing, then we can predict exactly what will happen.
So I'll do a follow-up question on that. And that is, you mentioned that you're missing one of 2 copies. Why doesn't the other one just work twice as hard so there isn't a problem?
We would love to make that happen. Like, that would be the dream, right? It would be ultimately to be able to make the gene that's there work better. The problem is that that's a little complex because genes don't have a mind. Instead, they're being acted on by all these other different genes to turn them on at the right times. Some things have to be turned on perfectly during development. And so if you have only half of the product that they're supposed to make, there's no other gene to make up for that, or even the other copy is not enough. We actually have a special word for that. It's called haploinsufficiency, meaning 50% is not enough. And this is what actually causes a number of different diseases, and we'll call them haploinsufficient. And again, we would just wish that the other gene would be smart enough to kick it up, but it doesn't work that way.
And of course, it's not just one gene, it's dozens.
Yes, dozens of different genes all working together, all integrated, all trying to do something. But yes, this is very hard.
And different genes in different individuals. right? Not everybody has the same deletion.
Sorry, that's true as well. So one of the first steps we always think about is what genes are deleted in your child, and does that help us to know the things that we should be looking for?
I'm just trying to make the point that it's really complicated.
And some of the genes actually do that compensation thing, and they cause autosomal recessive conditions. There are several of those in the 1p36 region. I looked that up earlier today to see what I might have to talk about today. And there are, in fact, some things that would be rare complications of 1p36 because the other gene does kick up and compensate for the missing copy. But that doesn't mean we can ignore those things. So some of the variability it gets really complicated.
All right, next question. And I've never read anything about this, and that is somebody commented that the kids tend to seem to have a lot of infections, have trouble getting over these infections more so than a typical kid. And is there any evidence, or is that a reflection of an immune deficiency or an immune system problem?
So we have in Cincinnati looked at this in a couple of kids. We have to date, I can't say that there is no immunodeficiency, but to date we have not identified an immunodeficiency in any of the kids. But the immune system is sort of the chemicals that your body uses to initiate inflammation, to signal the attack mode for viruses and other things. That part of the immune system appears to work at least reasonably well. There could be some subtle problems with it. There are other things that frequently predispose to problems with infections, and some of those are definitely a part of 1p36. One of them is hypotonia, because when you cough, if you're hypotonic, you don't clear the mucus and stuff out of your airway or your nose or wherever you're trying to get rid of it from as efficiently as you would if you didn't have hypotonia. Then the anatomic differences. If you look around this conference, you notice that there is a similar look that is distinct and unique to 1p36 deletion. There are also anatomic differences in the nasal passages and the passage from the middle ear to the back of the throat, the caliber of the tear ducts that drain the eyes, and those things being slightly abnormal at a different angle or smaller in caliber or things like that impact susceptibility to infections and the severity of the manifestations of the infection. How long is the duration of the infection? And that, I think, plays a bigger role than a true immunodeficiency. Now, I can't prove that. I haven't done a statistical analysis on it. But we do know from studies in Down syndrome, 22q deletion syndrome, and some other conditions that those things do, in fact, have a significant impact on the infections, so that the kids who have those abnormal anatomic structures manifest symptoms longer, are more likely to require interventions for infection. So I think that that's what's going on.
Yeah, I was going to say, I think the other issue is just an extension of what you said is, if you have a kid that has chronic aspiration, so they're swallowing such that stuff is going into their lungs, that can certainly cause infection. Anytime you have pneumonia or infection in your lungs and you treat it, there's probably some amount of damage that occurs. And if that's happening repeatedly over time, it's harder to recover each time, because you're sort of, you have some lung injury, you recover, but then you have another injury and it's harder to recover and it takes some longer time.
Yeah, and the longer you have residual inflammation in part of your body, the more susceptible and twitchy that part of your body becomes. So if you've had a recent respiratory infection, rather than having more resistance, you have less resistance to the next bug that comes along. And we also know that that is a part of the aspiration events, and with kids who have any kind of chronic respiratory or sinus issues.
And I think it's probably overly simplistic, but think of this like that ankle you sprained as a kid, and invariably when you twist an ankle, it's always that one, and then it seems to injure more easily, and it doesn't heal as well just because it's been injured multiple times. Not exactly the same, but close enough. So I think this is a Dr. Scott question, and that is, are there more genes in the 1p36 region than we currently understand, or are there genes that are there but we don't know what they do?
We don't know what most of the genes do, actually. And so one of the things that's helpful is, one of the ways to find out what a gene does is you find out what happens when you get rid of it. In other words, you take it out or you delete it. And so that's one of the reasons why we work with mice, is because we can actually go into a mouse and delete either one of the genes or both of the genes, both copies of the gene, and determine what happens in mice. And so there's actually most of the major genes, major meaning the ones we think most likely cause problems in humans, have been looked at in mice, which is a good thing. But still, we know we can't necessarily translate exactly what will happen in a mouse to a person. That's why, again, those big international collaborations where we have multiple physicians all looking for mutations in children with these is actually probably going to be the main solution for trying to figure out what the genes do. And so I would actually hope that within the next, I don't know, maybe the next decade, we will know what many of the most important genes do. There'll be other ones that will be less important, and they won't show up because the children who have deletions or mutations in them just don't have any symptoms. And so little bit by bit, we'll know the most important ones.
I just want to ask a question. Is it possible that some of them won't show up with any primary manifestations, but may be important in modifying other aspects?
Yeah, that's a very good question too. Just as a for instance, we have genes that we look at that are important for heart defects. And so we know that some genes are powerful enough all by themselves to give you cardiac defects, at least in a certain percentage of children. But we know that in mice, other genes that don't seem to be powerful enough to do that in humans do cause it in mice. And so those are potential modifiers. So in this particular case, the mice help teach us something, the humans help us teach something. But then again, putting those two things together is very hard, because it's very hard to find a person who has a mutation in just that gene and the other one. So the other way we can look at that is to look for kids who have a deletion that takes in both of those genes. And so in this particular case, we're also interested in identifying what are your children's deletions, and do they teach us something special about how genes that are in that deletion are working together. We have a database that we keep that has about 250 children that have been described that have 1p36, either from you sending us information or that being published in the literature. And so we can actually begin to say, well, if you take out this particular section, how often do those kids have this particular issue? It's not perfect because all the deletions are different sizes, right? And we wish we could order up a deletion that would be just exactly this size to teach us this particular problem. Instead, we wait and we just see if we can identify someone who can teach us that. But we already have found that there are certain things when you, again, delete two, that may be worse, or this particular combination is worse than just deleting either one by itself. We also do those in mice, where we cross mice that have two different genes, and we see how they interact. Both of those are ways to learn that.
So I'm lucky because I know like only a thimbleful of genetics. So these guys know a lot more details, and I only know like a little bit from medical school. But that also makes me much more simplistic. But here's kind of how these things also get complicated. There are genes whose function is to turn on and off other genes. So it sort of has layer after layer upon it, right? Because it's not just this gene has something to do with your heart. It could be that this gene turns on another gene or turns off a different gene on a whole different chromosome that may do a whole host of other things.
Yeah, so the main gene that we work on in my laboratory is a gene called RERE. It's kind of a little bit farther down on the chromosome. It's about 8 megabases in, or 8 million letters in. Some of your children do not have that gene deleted, other ones do. That particular gene is what's called a nuclear receptor co-regulator, which basically means it partners with all kinds of other different proteins to turn genes on. And so one of the main things we're trying to figure out is what are the genes that it turns on in the heart. We know some of them now, but we also want to know what it does in the eye, what it does in the brain, what it does in the ear, because this particular gene actually can do almost everything that's seen in 1p36 you can do by just hurting this one gene. And so basically every major symptom can be caused by just a mutation in that gene. So it becomes a really important one.
So it's a manager.
Yeah, so it's a major regulator of all these different processes. It actually combines with other master regulators to do all these things.
And I don't know, at least where I work, if you have a really good manager, that's a good thing. And if you have a really bad manager, it screws up many, many, many different things. So this is the analogy that strikes me in my head. Again, I get to be simplistic because I know just enough genetics and molecular biology to be dangerous. So here's one probably for Dr. Hopkin, and that is many kids with 1p36 carry an autism diagnosis or certainly have some features that we associate or think about with autism. And do you think that is part of 1p36 that some kids have? Is there some genetic relationship there? What do we know?
So this is autism is really complicated. There are at least a couple of dozen chromosome deletions that are similar to 1p36 in some ways, but distinct in others, that have been associated with autism. And 1p36 has been. Autism is defined by functional status, so we don't know a specific pathway in the brain. We don't know, it's not defined by a specific cause. It's defined by patterns of behavior, and some of those are problems with communication and problems and a tendency to ritualize behaviors and not making good eye contact and things like that. And so if you use that checklist and you say everything that has this checklist is autism, then there is definitely an overlap between autism and 1p36. And a lot of the kids with 1p36 will meet that criteria. On the other hand, if you say, well, if you have a known cause that's something else, then it's no longer autism, then you could say, well, then in that case, 1p36 has overlap with autism but is distinct. And there are people, researchers, who study autism who are in each of those camps, and they argue with each other at meetings, which is entertaining but not helpful. So the bottom line is, autism, some of the things that we are learning about autism and about the way the brain works through the study of autism are likely to be important and useful when we get the details worked out for kids with 1p36. There are also things about 1p36 that are distinct to typical autism, so that the autism literature will never answer all of the questions that we need to know for 1p36. So it's something to keep an eye on, work with. I also find that having a label that people have heard of is useful, especially when you're negotiating with the schools. So I am not above saying, well, you're kind of autistic-like, and the school will pay much more attention to that label than 1P36, so let's say you have both. And that is a completely pragmatic, unscientific approach, but it's useful if it gets you access to therapies or gets buy-in from therapists and educators because it's something they're familiar with and know what to do with. So use it either way.
Yeah, and having gone through the IEP process, which I'm sure many of you either are going to go through for you, those that have younger kids, sometimes to the school system, checking a box means a lot to them. For us, just having a diagnosis, even though they have no idea what 1P36 deletion syndrome means, that allows them to check a box that says Wendy has a diagnosis that is associated with known delay. If she didn't have that diagnosis, then she gets thrown into this category called other health impaired. So for them, they like to check that box because, again, it opens doors to services, it justifies what they're doing. And as Dr. Hopkin pointed out, that has nothing to do with the science of this or what it means medically for your child, but practically speaking, if it accesses services, yeah, check the box, right? I mean, you kind of have to play that game.
And several states actually have laws that say you have to cover services for children with autism. So if you live in one of those states, take advantage of it.
This is true. In Maryland, it pretty much automatically qualifies you for disability services just by having that diagnosis. So, I am very grateful that Wendy is very social. Unfortunately, she won't get an autism diagnosis so that I can access services tremendously easily in Maryland. And it's just one of those strange, weird political things. So shifting gears and throwing the obvious question to Dr. Scott. Hey, Lily. I've never felt so loved. Man, why couldn't this have been high school for me? What about gene therapy, stem cell therapy, some fancy whiz-bang thing?
Fancy whiz-bang things are not probably in our near future, sadly. One of the questions I was reviewing some of the things that have been asked, and one was specifically about stem cell therapy. We use stem cells therapy. We've been actually doing that for like the last 50 years. We mostly do it in bone or like blood-making cells in the bone marrow. And so when you think about treating a cancer, one of the ways to do it is you destroy all the cancer cells and then you give somebody back a new bone marrow that's using stem cells that then generate all the bone marrow and then they make the blood that's needed for that patient to still live. And so we do that. Stem cells right now, as far as I can tell, are being used for those kind of blood problems. There are some grafts that can be done using stem cells that are for skin, for bone, and sometimes for the cornea, which is the outer layer of the eye. This is super hard to think about using for something that's, say, a neurological problem. So let's say developmental delay or intellectual disability. One of the reasons is not only do you have to have a cell that can actually make a neuron, but it has to be able to go in there and insert itself in the correct way as to actually do something. And sadly, we're just not to that point. And so a lot of the changes that are seen in our kids are changes that happen when they were super small, so even before they're born. And so replacing or making a change there is actually extremely complex because you don't have to like strip away a nerve and then put a good one in its place. Or to even try to say, well, can I change a gene in a cell? I've had several people now who have asked me about things called CRISPR-Cas9 technology. I don't know if that's hit you yet, but it's a way that we found in science to make changes in cells. But we're usually making changes of one gene, not 230 genes. That is a completely different prospect. I mean, that is very, very far away to be able to put back like a huge piece of a chromosome. And so even the limitations that we recognize in identifying one gene that we can change Those are limiting enough, but again, for a chromosome, even harder. And so parents say, well, so what do we do? Many of you are already doing most of the most important things that you should do, which is therapy. Therapy becomes the medicine for most of the things that we're thinking about, but also working with doctors to be able to keep pieces of the body healthy, like going to the cardiologist and making sure that the heart continues to be good and working correctly, making sure that hearing works like on a yearly basis to make sure you don't lose hearing at some point and that compromises communication, or making sure vision's good. All of these small things that take time, that's really what makes sometimes the biggest difference in how kids do, is being able to just keep kids healthy and also, again, maximize the abilities that they have through therapy. I go on a regular basis to Guatemala, and I see kids who have the same disorders that we have in the United States, and yet they fail to have the therapies that our kids have. They're dramatically different. And so I see the same problem, but again, the consequences are hugely different. We're extremely blessed to live, or at least most of us, again, live in countries where we can have access to these kind of therapies. It just makes a huge, huge difference for our children because of that.
So I want to comment on that as well. Yesterday we heard a lot about the behavioral management and having, looking at your child's behaviors and figuring out what drives them and then doing little changes and additive changes over time to modify those. And that seems not very sexy or exciting compared to gene therapy or to stem cell therapies. On the other hand, we don't have a lot of data on how much difference that makes in 1p36. I think I would love to get that data, but I have gone and looked up the diseases, some of the diseases that we actually do have data on. So Down syndrome, Marfan syndrome, neurofibromatosis type 1, Williams syndrome, Fragile X syndrome are all conditions that are fairly common and have a lot more study on them than 1p36. They are also all conditions where we don't have something like gene therapy or a specific drug that treats them or a specific surgery that treats them, where we just manage the symptoms. So let's go through them quickly and say, well, how much difference does it make? So 30 years ago, if you had a diagnosis of Down syndrome, your parents were told, don't expect much, keep them out of the public eye, and you should look for a long-term care facility to put them in. And the kids lived down to those expectations. They didn't do much. They were usually dependent for all care, and the average life expectancy was right around 20 years old. Some of the parents said, that's ridiculous. This is my child. I'm not going to do that. I'm going to show you that you're wrong. And the researchers who were interested in Down syndrome looked at those kids and said, wow, the people that hate us, their kids are doing better. We probably should change something. And the early intervention programs that your kids benefit from grew directly out of that, because they found that if we engage the kids, they do better. So now the life expectancy of Down syndrome is about 60 years, and the degree of independence that they have is about half of them move out of their parents' home, usually not into complete independence, but into a semi-independent life. About half of them are employed, not enough to meet all of their needs, but enough to give meaning to their lives and keep them busy and out of trouble. And what caused that? It's the same kind of behavioral management that the talks were on yesterday, along with the management that Dr. Scott mentioned earlier, where you look at the vision and the hearing and the heart function and the seizure control and those things. So with the tools that we already have, we can make a tremendous difference. In Down syndrome, we've tripled the lifespan and improved the quality of life. Marfan syndrome, we've tripled the life expectancy and improved the quality of life. And for the other conditions that I mentioned, we haven't, for some of them, tripled the life expectancy because they weren't that life-limiting, but we have improved the outcomes for all of them. For every condition that we have enough data to know what we do, the day-to-day simple management that's not high-tech makes most of the difference. So use those tools. Don't let anyone tell you that this is not an actionable disease. The effort that you put into your kids every day does change their lives.
Okay, I just want to take a minute here. Childcare needs to close, so if you have a child in childcare, we're going to keep going here. I'm not going to shut these guys down. They're willing to talk to us, and I'm going to keep going. But if you have a kid in childcare, if you could go up and get them, I understand the volunteers are reached their limit. We're going to close at 4:30 anyway. It's like 4:25. So, but we'll we'll keep going here. And you know, I again, my experience as a pediatrician, not with 1P36 kids, because in practice I never saw one, and until I came to my first conference, I never met one other than my daughter. So it was very eye-opening for me. But in general, kids with any sort of delay, my experience has been early intervention, more intervention, earlier intervention really does seem to make a difference in someone coming closer to reaching their developmental potential. So, I mean, to me, the real practical advice is, you know, whatever you can access to help your kid is the thing to do.
And consistency. The consistency that several of the speakers at this conference have mentioned is really important because it's harder for these kids to recognize the patterns and their ability to communicate and function, and so ours also is dependent on recognizing the patterns. So if we can simplify the patterns of their lives a little bit, but not so much that it makes it boring, they're going to do better.
Yeah, and that consistency is incredibly difficult. You know, behavior management is incredibly difficult, right? I know a little bit about behavior management, and I've now had a year of a great Kennedy Krieger psychologist wandering around my house telling me how to do it, even though I know a little bit, and I still don't get it right. So it's really tough, and it's really tough to do at 3 a.m. We have a couple more sort of the prepared questions, and then I can go around the room. But just somebody asked a question about pica, which is the sort of chronic ingestion of non-food substances, dirt, chalk, whatever. And certainly a number of kids, including mine, are completely obsessed with water that has nothing to do with thirst, but they just like to play and excessively drink. Any thoughts on why?
It's a sensory issue, the same thing that causes most of the repetitive behaviors, and it's been a major theme of this meeting, but they both use those sensations to avoid things that are bugging them and to increase stimulation. Now, why do some of them like things like eating dirt? That I can't answer, except that it is a stimulation. So the best interventions for that are going to be things that provide stimulation, but that are more socially and hygienically acceptable. And so finding those things can be very difficult, but you pay attention to the patterns that your children are establishing, and you find ways of intervening to modify those, and hopefully you can find some things. Now there are, for some of these stimulation seeking, there are medications that can help. Interestingly, antidepressants are one of the categories that can help with this obsessive behaviors in some cases, but all medications have some side effects, so we don't use them as the front line. And you would want to work with a developmental pediatrician or a psychiatrist to work on that kind of medication, because you're talking about atypical use of established medications.
Yeah, and I totally agree with that. I mean, as a general pediatrician, and admittedly I've not practiced in the last 8 years, but I did practice for 12 years before that every day, and the general pediatrician does not know squat about things like antidepressants or using some things like typical seizure medications in the context of behavior medications. So really important to get the right person involved. And you know, my daughter is just incredibly crafty. She now figured out I have a bird bath in my backyard. She used to slurp, and you could always hear the slurping. That gave her away. She's now figured out that she can get a plastic cup and go over and scoop out of the bird bath or the dog bowl, and she can drink out of an open cup. So now she just goes, and that's quiet, because she knew the slurping is giving her away. So they're just, in some ways, so limited, and yet in other ways, so crafty, which is just fascinating to me, watching this happen in my house, of like, there are some things that you just struggle with and can't get. She doesn't talk, but she can figure out how to go get a cup, sneak over. She figured out within 2 minutes in our room how to find a cup, turn on the faucet, and get water and drink it. You know, and every you know, faucet handle is different, right? Now, she turned on the hot water, which is not so good, and it's also not that fun to drink, but like right away, she figures out where's the water, how can she access it? So it's just, I don't know, I find that sort of just interesting and novel. And here's one question. I talked about this briefly with Dr. Scott, and this will be the last one before I go around the room. Last year, excuse me, and that is, it seems recognized that this is a female predominant syndrome, 2 to 1 female or something like that. What do we think accounts for that? Is that boys are more severely affected? Are there more boys that die in utero for some reason that we don't know about? Does that account for it? I don't know, but it just strikes me as, you know, there are clearly some things that show up almost only in males. Hemophilia, red-green color blindness, those sort of things that are called X-linked. But this is chromosome 1, has nothing to do with gender determination, yet it's female predominant.
So several of the chromosomal abnormalities that are well described are female predominant. In some of them, we know that that is because the females are more apt to survive, and they therefore do better. We don't know the biology behind that, but it's a fairly common thing, and it's different than being X-linked or sex-linked. It's sex-influenced manifestations that we're seeing, and I would be curious if you have any thoughts on the genetic basis for that.
I have no idea. It was really interesting, because actually the first time I had not looked at the literature to see if that was true. I actually was coming to this conference that I'm like, wow, there's sure a lot of girls around here. And then I started thinking about all the kids that I deal with in the clinic, and I could not think of a boy. I couldn't think of one, like off the top of my head. Maybe I have them, but I just couldn't think. All the ones that came to mind were girls. And so, but there must be, again, a reason. There are a lot of kind of complex genetic things where boys are at a disadvantage for all kinds of great reasons. We're just kind of just fragile. Anyway. But no, I don't know the answer to that one.
I think this is another thing where I can say that we're sort of at chapter 1 in learning about this. So for a long time at FDA, what I did is I was an epidemiologist. So epidemiologists are people that describe patterns of disease. So the first thing you do is you think about age, sex, race, and ethnicity, right? They're the first things you think about. Who does this problem affect? Does it affect a certain age group? Does it affect males or females? And is it different if you're Caucasian, Asian, Black, Hispanic, whatever? So we don't even know why. We know the observation is that it's female predominant, but we don't know why that happens. So I think that kind of tells you, in some ways, our knowledge is quite limited here. I'm happy to take other questions. Those are questions that people emailed in, and I thought we should cover those if people took the time, and now I'm just happy to sort of go around and take questions.
So this question's kind of specific to my daughter. When we found out that she had the deletion, we were told that it's Mosaic. So they only found it in 76% of her blood cells that were tested, meaning that 24% of them had the 1p36 gene there. Now, when we were talking about the stem cell, is it replacement or however you do it? I mean, is that a possibility for her, or what does this mean, or what can that do by having this in by having this gene in 24% of our cells?
So when you're Mosaic, it does potentially give you a little bit of protection. And so Mosaic, again, is just exactly as you described. Only a certain percentage of cells in a specific tissue are affected, and then the other ones are just normal. How can that happen? Well, when you make a single egg or sperm that comes to united in a single cell, that cell begins to divide, and at some point you can either have damage to a cell that then goes on to make part of the body, or sometimes you can actually have a bad start and you can actually rescue that, either one. Rescuing meaning that through certain processes that are difficult to describe, you can end up having a replacement happen in some of those cells. What does it mean as far as being able to do therapy? It probably does not make a huge difference, sadly. I mean, you have a perfect cell line, but accessing it and then using it is very difficult. And so it may not make a difference. One of the things to think about in kids who are Mosaic is that you have now determined what the mosaicism is in blood, but you do not know what the mosaicism is in brain or heart or anything else. So although Mosaic children can sometimes be less affected, I can still say that they will scooch around anything in particular. And so sadly, we will still look at them as being at risk for all the normal stuff. We just, again, would hope that some of those important organs like brain may have enough normal cells to be able to compensate and help out.
Mosaicism is also dynamic in some tissues. In blood, it is more dynamic than the other tissues. So if you have cells that are having a hard time turning over, then bone marrow particularly, which means the cells that make the blood cells, the healthier cells tend to do better, and the cells that have the genetic mutations like a deletion tend to be eliminated. So you have an improvement apparently in the blood that doesn't take place in the other organs. So it is, it's fairly common for some disorders to see elimination of the abnormal cells from the bloodstream, even though the rest of the body clearly remains affected with that condition. I don't know if that happens with 1p36, but it may not be as high of a percentage of normal cells in the rest of the body.
My question is about whether a condition has been found in the studies, or where you guys have pulled together what you've seen from us and others, because I don't remember hearing that it was, and it's a new finding for us. It's polymicrogyria.
So polymicrogyria is common in 1p36 deletion, and in fact, it's common enough that a neurogeneticist that I talk to from time to time predicted that that would be the explanation for the speech problems in kids with 1p36 deletion, because it's commonly associated with oromotor problems. It turns out that the speech problem isn't nearly that simple in 1p36, but the polymicrogyria is a common association with 1p36 and should not be considered a new distinct diagnosis. It's a new manifestation in the patients that have it when it's discovered.
And polymicrogyria is basically a structural defect of how the brain is shaped and put together.
Yes, it's the folding pattern that causes the wrinkling on the surface of the brain is different, so that you have less defined, smaller undulations on the surface of the brain than you would expect to see if you didn't have polymicrogyria. So the technology that we use to do MRIs has improved. The resolution that we can get on the images is much better. Might be that the details that they were looking at are different, and it becomes easier to see polymicrogyria as the white matter in the brain matures and the myelin gets completely mature. That makes it easier to see, even though the problem would have been there earlier.
I know there was a question somewhere over in the, there we go. Sorry.
Okay, so my son was diagnosed with CHARGE syndrome. I don't know if you're familiar with that, and 1p36. How do scientists, geneticists, just differentiate between the two when a lot of them are, from what I've read, they overlap, like a lot of the similarities. So how do I know like what came from what?
So just to double check, actually she'll need to answer something for me. Does he actually have mutations in the CHD7 gene?
The CHD7
Okay.
and the 1p36.
So sadly, there's a lot of children who actually have more than one genetic diagnosis. And so now that we do these kind of broad screens where we're using chromosome microarray analysis and whole exome sequencing, we find that of the kids that we end up seeing that we diagnose with something with whole exome sequencing where we look for the mutations, about 4 to 5% have 2 different diagnoses. And so sometimes things just happen by chance. How you differentiate what things are from one and what things are from the other, in this particular case you can't, because they're mixed in a single individual. And so all you can do is say that some things that are more specific, like the anal issues or whatever, would be a CHARGE thing versus a 1p36 thing, but you're really dealing with both disorders, and you have to deal with both of them and think about what do you do to keep a child healthy if they have one or the other, and you've got to do both. Extra work, sorry, yeah. But you are not the only one who has, again, a child who has 2 relatively rare disorders. We see this kind of all the time now.
With 5 or 6 billion of us on the planet, statistically speaking, it happens. Okay, more questions. We'll go here, then here.
Kind of following up that question, our son was diagnosed 8 years ago. Would there be any reason to get another genetic test done, or another, just because technology has changed and maybe there's something else to be looking for or watching out for?
Yeah, we actually recently had a company who came and talked to some of the people who were kind of in the know in the 1p36 and suggested that maybe, again, people who have been diagnosed in the past might benefit from having a higher resolution of the chromosome microarray analysis that gave your diagnosis. In most cases, although the technology has become better, we're looking at a big change, huge change. And so that will be caught just as easily on 10-year-old technology as it will be on brand new technology. And so in most cases, the answer is no, not very helpful. There are occasional people, but again, they would be extremely few, who may have been diagnosed with what's called telomere fish, which is a not very old technology, but older. It doesn't tell you the depth of how far that deletion goes into the chromosome. Then you could say, well, there may be some reason to say, well, would you like to know the exact genes that are deleted? And might that somehow help you in the future to know what you might expect? If a child is also 14, 15 years old, you've probably seen most of the issues you're going to deal with. And so getting another one would not be particularly helpful. So after talking this over, we said that globally we would not recommend this. Instead, it would be really helpful if a doctor says, I need to know whether this particular thing is changed because I will do something about that differently, then let them order the test. But as far as globally, would I say or suggest that so you get new, better technology? No, it would be mostly a waste of money.
Hi, I'm from England and we got diagnosed at 2.5. Can you guys tell us when it could happen between conception and kind of giving birth? Because I got kind of told they don't know.
Conception. We're assuming that the errors usually, almost always, would be in this egg or sperm that came to form that child. Which also, by the way, means that this is a no foul, no error kind of disease. And so if you say, well, is this a mom thing or a dad thing? The answer is no. Is this a drink, something, an alcohol I drank during first trimester? No. This is just something that bodies make mistakes when we copy the DNA. In this particular case, the mistake is quite common because the chromosome is so big, and we have to assume that that's the reason why this typically happens. But no, for the great majority of cases, there's nothing that's special or unique. This just happens at conception. There are a few families where the chromosomes are actually changed, and that one particular parent carries a change that sets them up for having children that may have this more often. That would be a special condition that even in the mother or father's body is actually changed, that then leads this to this being more likely. But again, that also would happen at conception.
And I think from what I've read, the published literature says that probably 90 to 95% of parents have normal chromosomes, and then that other 5 to 10%, someone might have that balanced translocation that you describe.
The mosaicism, cases with mosaicism are a slight exception to that, where it's probably not at conception, but in the first few cell divisions after conception. So it can happen after. Typically, that would lead to potentially some degree of mosaicism.
All right, going all the way to the back.
It seems like from what you're talking about, data collection is a major issue with 1p36. You just don't have enough research information. Is that true? And is there anything being done to expedite the process of collecting data? Is there any kind of computer systems working? I know I've heard of like IBM Watson working on stuff. Is there any other programs or ways to get studies?
So the answer is yes, we need more data, and there's actually a lot more data that could be used. Registries are one way of getting that data collected. There is some cost to those. The IBM Watson computers are actually being used for some of this stuff. There's a company called Think Genetic that is trying to data mine everything on the internet with answers to specific questions, and has the potential to pull some stuff out, but probably not in a vetted way that would allow us to data mine and make new discoveries, but it would allow more efficient access to what has already been published and reviewed. But I think that the best answer for ways to move this forward would be to find a way to have some kind of a registry, and you would need with that a board of physicians who are willing to give time to helping identify and prioritize questions, and a board of parents who are willing to also give time to identify and prioritize questions, and then people with the statistical ability to mine that data and look for the answers. That can be done without super high costs, but it takes somebody with a lot of time, so there is a certain amount of cost that goes into it.
Yeah, I mean, honestly, there's no reason we couldn't sit down and come up with a patient registry. And honestly, in my professional life, I work with some patient registry data. But think about trying to find a person, even at this conference. What a registry entails is taking a very complicated questionnaire or set of medical history from each person, then getting in contact with them every 3 months, 6 months, year, whatever it is, recording all that data again about what's changed. So it's enormously effort intensive to chase people down, because even you could email that, but how many people are going to email that back? And then you got to email them again and say, we need your questionnaire. And then you're going to have to call them, and then somebody has to enter that data, and then somebody eventually has to analyze that data. So you can see how it can be very time consuming and time-consuming generally translates into it costs money. The real way to get research done is money. That's my line from my talk yesterday. If you are, wealthy, politically influential, et cetera, or a celebrity, see Ken. Because what drives research is the ability to pay for research. If you have money, someone will gladly do that stuff for you. But that's tough, and it can be, not millions of dollars, but it can be tens of thousands of dollars, and that's not easy to raise that kind of money.
I would just say that that's true. I mean, if you say, well, Daryl Scott does a lot of 1P36 research. My lab right now has myself, 1 grad student, and 2 staff scientists. There's 4 of us. And we do as much work as we can, but we have far more questions than we will ever have ability to do in our lab because we just cannot move fast enough. And so yes, I mean, there's only so much you can do, but it's very expensive to do this work. And most of that ends up being just buying people's time.
So a new-ish option that is gaining credibility and used to be unpublishable but is now being not only accepted as potentially valuable data, but is actually being requested by researchers and mandated in some cases by the FDA for long-term follow-up studies in which drugs are involved, is patient-reported data, which would not require somebody like me or Dr. Scott to enter the data into a database, but we would trust you as the families of the patients to do that. That can save, or at least diffusely spread the costs that would be required to do this, but you would still have to do the entry. I've worked with a number of registries, and typically for any given data point that we require, we have adequate data to analyze for about 1 in 10 people in the registry. So you need literally thousands of people in a registry to be able to use, if it's at that level of input, to be able to use that data. So we would need a lot of commitment from a number of families so that they would be willing to enter the data when they see a doctor, get a test run of any kind, that goes in, and it would still require somebody to build the registry, define the data plans and the analytic plans, and that has to be done before the data entry can go in, and typically the design of the database takes around a year or so once you've got people with the time and ability committed to do the project. So it's a big but not impossible project.
All right, we're approaching follow-up, 5 o'clock, so I'm going to do follow-up question. Sandra, I know there was a question in the front, and then I think we have to do the quilt drawing, and there's something else we're supposed to do. And then, but, Dr. Scott and Dr. Hopkin, look, just to come here and spend several days with us and be willing to hang out with us and go to the baseball game, I mean, look, they're not a 1P36 family, right? They don't have a kid with this, but they're genuinely interested and take the time to come here, which I very much appreciate, as all our speakers. But it's terrific they do that, and they've done it multiple times. So I want to do a couple more questions, but I think they'll probably be happy to answer questions on the side, but there are some other things we need to do, and I know there are people in this room just because they want to see if they win the quilt.
I'll just say that I'll put a bunch of my cards up here. As long as you're really patient with me, I don't mind answering an occasional question. It's just that every time I get an email, then I have to do that versus something else. But it's reasonable. I often get emails from you, and I appreciate your interest in the research that we do, and we would be happy to answer, especially a very genetic-focused question. I can usually do that pretty fast.
All right, we got 2 more to go here.
I agree.
All right. I just had a quick question. I am a carrier, and that's why my son got the 1P36. And I heard that there's very few that get it because their parents are a carrier. So my question is, because I've also, back it up a little bit. I heard the parents that aren't the carriers, they're typically fine. Well, in my case, I was developmentally delayed in many ways, and I had major behavior issues. And a lot of people didn't even think I would be able to live on my own, and I am. So my question is, where do you guys get the, I don't know what you call the data or whatever to say this stuff?
So there's a number of possibilities to answer your question, but the way we get the information that only about 5% of the patients have a predisposing chromosomal rearrangement is that in the cases where we have identified children with a deletion and then looked at the parents, only that percentage of the parents had a predisposing change, and most of those parents that have a predisposing chromosomal rearrangement have normal function when we have interviewed them. Now, there is a possibility when somebody has a balanced, meaning no DNA is missing, rearrangement of chromosomes, that the break point in that disrupts one or more genes, and that can then be symptomatic. So if somebody has a balanced rearrangement of their chromosomes, about 1 in 10 of those people will actually have some kind of a medical or developmental problem related to that. And it seems possible that that is what's going on with you, that your specific breakpoints in your rearrangement disrupt one or more important genes. There is actually a group that studies that kind of rearrangements and tries to identify exactly which genes are disrupted. If you're interested in that, I would be happy to talk to you a little about it.
All right, we're going to do one more question.
Hi, I have a kind of a two-part question. Our kiddo has polymicrogyria, and when he got diagnosed with that, they told us that there's some cases of kids who have polymicrogyria or grown adults that it's never affected. Like they're just walking around, typical, happen to have an MRI, and they found out about that. Could there be anybody with 1p36 that is typical and they just don't know, or does it affect people 100% of the time? That's kind of first part. And second part, is there any data or resources that have been collected to indicate what makes a kiddo with this more higher or lesser functioning?
I'll do the first part. So one of the things that we have to always keep in mind is that 1p36 means something different for every person in this room. And so everybody's deletion is a different size, or most likely everybody's deletion is a different size. Are there individuals who have pieces of 1p36 that are missing and it causes no symptoms? The answer is certainly we could think of a very small change on 1p36 that hits certain genes that really are not required. And so yeah, almost for sure there's individuals who are walking around with a 1p36 deletion. I could be one. And it just doesn't affect important genes. Most of the people who are here, though, have a very large deletion, and that would be less likely to be asymptomatic. Because again, the bigger you get, the more genes that are involved, the more risk that you have, and therefore the more likely it's going to be that you'll have symptoms. And so again, it's kind of different. If you said, well, how many people have the exact same change that my child has and have no symptoms, it may actually be 0. Does that make sense? Because that piece would be so big that we would think that everyone who misses that much DNA would be affected. And so again, it's maybe not exactly the question you were asking, but that's the best answer I can get. The difference between severity, I'll go for that. Probably the easiest thing for you, even though it's kind of odd, most of you know probably a child who has Down syndrome. So I know kids who have Down syndrome who are very, very affected, and yet they have the exact same change as some of the kids who seem to do very well. Why is that? Part of that could be environment. And we talked about how the difference between environment makes a difference in how kids turn out and how well they do. But part of that also may be because of the background, we call it the genetic background, that's influencing that. In other words, I have 7 kids. Some of them may be smarter or better than another one in certain sports or whatever, and we expect that. Like, well, yeah, like no 2 kids are the same, right? That's because of genetic background. There's differences in each child. Well, each child with 1p36 also has unique parents and has a unique genetic background that they're going to be based on. And so we think that those kind of influences make a difference also in whether a child does better or worse. And there are probably, again, even little tiny like molecular changes in how each gene functions that makes a difference in that too. So that's why we have this spectrum. To give you one more example, we can see kids who have the gene I work on, it's called RERE. On one side of the spectrum, they have only autism. That's it. On the other side of the spectrum, they have severe developmental delays, intellectual disability, cardiac defects, eye defects, and they look completely different than the kids on this side of the spectrum. And that they have the exact same mutations, and the difference is genetic background.
So I don't have a lot to add to that. And the polymicrogyria, as I mentioned earlier, is frequently associated with 1p36. The diagnosis of 1p36 deletion is much more predictive of what you should expect than the MRI finding. And so I would not make a lot of focus on the polymicrogyria. I would focus on learning your child's needs, and if you are going to look up some of the scientific or medical stuff, I would recommend focusing more on the 1p36.
All right, I just want to thank these guys, first of all, for coming year after year and sharing their knowledge and bringing it down to our level. But second of all, you know, it's much easier if we let them put together a canned talk and they come up here and they just read their slides because they know what to expect. But they volunteered just to let us throw questions at them. And you know, I mean, I made a list of things ahead of time, but in general, they have no idea what you're going to throw at them. And there is nothing more intimidating as a speaker than just standing there and letting people just lob questions everywhere from left field at you and trying to field them to the best of your knowledge. Because when you give a talk, you can go and read all the stuff you want to talk about, and it's all right there, and people are going to ask you about what you already talked about. But in this case, they volunteered to just let us throw stuff at them. So we hadn't done that before, and I think it was great because you can see that we touched on a lot of really important topics for different people and questions that probably wouldn't come up in a routine talk. So I appreciate these guys very, very much, Drs. Hopkin and Scott.